And just give it one more moment, and then we'll go ahead and start with some announcements, and then we'll introduce Greg. Okay, why don't we go ahead and get started? I would like to just do very, very brief introductions. It's good to see you again, Greg. I know you know me. I think I know everybody here. So, Dawn, I don't know if you guys already introduced prior to the start of the recording.
Yes, we
Okay,
did.
great.
Thank you.
So, why don't we go ahead, Dale?
Yeah, Dale Lefevre. I'm emeritus faculty in family medicine.
Ariana?
I'm Ariana. I was a 2023 MDisability intern and am now a research assistant for the department.
Awesome. Liz?
Hi there, Liz Katz. I am a science communicator with the Department of Family Medicine, and I also help promote MDisability.
And Lisa?
I'm Lisa. I think I'm wearing the same glasses as Liz. I just realized.
Yes, I like that.
I am an associate professor in the Department of Learning Health Sciences and Family Medicine, and I get to be involved with disability.
Great. And Tyler James, so Dr. James is an assistant professor here at family medicine. It looks like he is virtually not driving, but in his car, not available. So let's go over to Samia.
Hey everyone, my name is Samya and I am a research project coordinator for the Student Accessibility and Accommodation Services, or SAAS. And I'm also actually in the process of moving right now, and so that's why my camera is off and I probably won't be talking very much because I'm packing, but I'm excited to be here and listen.
Awesome. And Samantha?
Hi, I'm actually a clinical research manager in internal medicine, but I have a daughter who's deaf and I'm involved in community advocacy.
Wonderful. All right, welcome. All right, so just have a couple quick announcements. I want to thank everybody who was involved with the summer internship reviews. We had 53 applications, and so that was the most we've had for our 4 slots. One of them is going to be sponsored by the AHEAD DC, which is the grant that we have under NIDLR. And so one of the slots will be sponsored by them at the Center for Disability Health and Wellness. The 3, like we have done in prior years, will be under the sponsorship of MDisability. And so we'll be in touch in terms of upcoming webinars, seminars, and we will hopefully have another wonderful year. I am blown away by the applications, the quality of the interns that we have. I'm looking forward to them joining. I think everybody's going to have a lot of great times working with them. With them, sorry. And then the other thing I want to do is just briefly mention the 3 that we do have with MDisability and the one with CDHW. So we have Michael Andres, Tess Krishner, who's she is going to be with the CDHW, and Muhammad Othman, and Alexander, her nickname is Sandy Wong. So we'll give more information to everybody. There will be a news brief on that. So welcome to those 4. And then the other one I would like to do is to have an open call for potential ideas for upcoming webinars and also for the grand rounds. We have a scheduled slot for October, and we are looking for speakers that can touch on disability health, mostly in a primary care setting. So if you have ideas, we would like to just kind of vet them and see if they'll be willing to present in October. So if you have any ideas, please email me and Dawn or put it in the chat. Okay. Okay. So I am delighted to go ahead and present. We have Dr. Mannarelli who is joining. So he has already provided audiology services for me, so it's great to see him again. And so he is actually involved in the Department of Audiology. He's very busy. He actually is involved with 3 different teams within the Division of Audiology. He works in interoperative monitoring team with a focus on preserved hearing and facial nerve function. And this is done during the mostly skull-based surgeries. On the pediatric audiology team, he completes diagnostic evaluations with a focus on electrophysiological assessment of infant hearing. And finally, he is part of the adult hearing aid team dispensing hearing aids at the West Ann Arbor site. And in addition to the clinical duties, he also co-founded Hope for Hearing program. This is an ongoing outreach program that provides used recycled hearing aids for patients at the Hope Clinic, which is a free clinic that we have in Ypsilanti. So with that, I am going to turn it over. What I'm hoping to do, we can learn a little bit more on some of the services that they provide and how we can better work with their department. So, and Greg, we will have this also be a recording and a resource to share with our department too. So thank you so much. Greg, I think you're muted, but we can definitely see your slides.
Yep. Okay. Sorry. Yep. I muted myself while you're talking. So the title of this talk is Hearing Screenings at the Bookends of Life. I was asked to talk about hearing screenings in kind of older adult populations and newborns. And so, which are both pretty dense topics. But I'm going to try to do each one in about 15 minutes, leaving plenty of time for conversation. If you have a burning question, just pipe in. I always say I'd rather have a good conversation than get to every slide in the presentation. But hopefully we'll have some time for discussion. A couple of disclosures or comments about this presentation. The first one is that the title of the talk is entirely inaccurate. For the adult populations that we're talking about, these people are generally nowhere near the end of their life, but it was just hard for me to pass on the catchy title. I do very briefly talk about staffing issues and wait times in the adult audiology clinic. So conceivably, my role as the unit chair for the union that represents audiologists could possibly bias my opinion, so I thought I would disclose that. The other thing I wanted to say was that I do see the follow-up for some of these newborn hearing screenings, but I'm not a part of the bigger program. I mentioned I was doing this presentation, and I talked about to our EDI coordinator here in audiology, which is Dr. Katie Kaboshek, and she basically said, if you guys ever want to do a deeper dive in this topic, she's always looking for collaborators and ways to reach out and improve her numbers. So I would at least give her a plug in this. I also, I put a lot of research data in this presentation. I'm mostly doing that as some eye candy. I'll point out some interesting things. If I really start to nerd out on the data, I'll never get through the talk. So, but I'll try to point out some things I think were interesting in the talk. So that being said, we're going to start with the EDI program. So it stands for Early Hearing Detection and Intervention. If you're not familiar with it, EDI is a federal program passed by Congress with the goal of giving a newborn hearing test to every baby that's born in the country. Basically, the federal program funds state programs, which then help fund and support both the birth hospitals and then the kind of follow-up diagnostic centers, and they're the ones that track all the data and then help also help support getting families to these appointments or getting reminders in. So doing a hearing screening on every baby in the country is a pretty big undertaking. You know, so before you do something like that, there's generally certain criteria you're going to want to meet, you know. And one of those is that you have to be a sufficient prevalence or incidence of the problem to justify screening an entire population. But we know that 1 to 2 out of every 1,000 infants are going to be born with hearing loss. I've also seen other stats where say that's 2 to 3 per 1,000. And then the other thing that's important to know is that 90% of babies that are born with a hearing loss are born to parents with typical hearing. So that means there's not going to be, you know, parents who understand sign language or have some other form of communication talk with a hearing impaired child. You have to have some evidence that that the screening will detect the problem earlier if you do it than without. Prior to the newborn hearing screening, the average age of diagnosis was over 2 years of age before we started screening universally. And as we'll talk about later, that's far too late to make meaningful or, you know, impact. You know, and now our goal is to have a diagnosis done by 3 months. You have to have the availability and ability to actually perform diagnostics at children that young, which we do. There's 2 tests you can use to get a hearing test on a baby. It's called the auditory brainstem response, or there's another thing you can do called auditory steady state response. Both of these are basically looking at brain waves in responses to sound to determine if the ear is working. And then you have to have some sort of treatment that is available immediately. If you can't start early treatment, there's no point in finding out about a problem earlier. But you can certainly fit hearing aids immediately on children. You can put in a cochlear implant around a year. You could start sign language or other kind of communication modalities at that time too. So you can certainly start that. And then you have to actually show that your early intervention matters. And basically, we've been able to show that children who receive early intervention will eventually catch up to the normal hearing peers. Those whose intervention starts late do not catch up. And I have some data on that, a little bit of it in the talk. So, here's kind of this was the kind of what we will usually refer to as the landmark study that demonstrated that early intervention works in children. And this work was done by a professor named Christine Yoshigana Itano in the late 90s, but it was really built on the work of Marion Downs, who was the audiologist who pioneered intervention in hearing loss in the 1940s. She's got a really interesting story. You know, I think every profession has the kind of the story of the forerunner who that everybody thought was, you know, either causing great harm to patients or a quack or completely off base, but ultimately was found to be completely right. And she spent decades doing research and training mentees, and ultimately was entirely justified that her idea that intervening early in hearing loss makes a difference. You know, believe it or not, like, you know, she was told, oh, you can't put a hearing aid on an infant because their hearing nerves aren't myelinated, cause damage. And so, anyways, this data, just a quick point out, is showing, you know, language benefit for the kind of the ones that get intervention started by 6 months compared to the lighter one with no months. And there are clear statistical advantages across the board in terms of language performance. And this study has like 3 other slides like this of different factors. And really the only thing that really moves the needle is the time that intervention was started. And I remember in grad school, this one always impacted me, which was the knowledge that a child born with a profound hearing loss that gets intervention started by 6 months will do better than a child with a mild hearing loss that gets late intervention, right? Where the degree of the hearing loss isn't as big as a deal as when you start managing it. And then you can't talk about the Joint Committee on the Joint Committee on Infant Hearing. This is the group that it was founded in 1969, and they provide the kind of this consensus recommendations for identification and management in infants with hearing loss. In 1969, it started uh, with the American Academy of Ophthalmology and Otolaryngology, the American Speech Language Care Association, and the American Academy of Pediatrics. Since then, it's grown to a much larger group of involved parties that kind of go in and every so often come up with recommendations on management for these children. So the goals of the EDI program, we call them the 136 goals. And so generally the goals are nationwide goals are to do the initial newborn hearing screening at no later than 1 month of age. So that's the 1 and the 136. That screening is done in hospitals, generally by nurses, technicians. To do the hearing screening, you don't need an expert in hearing loss or electrophysiology. They're all automated tests, and you get a pass-fail or a pass, what they really call it, refer, trying to find those that need to be identified earlier. The 3-month goal and the 6-month goals are pretty much on audiology, but we would like to have the diagnosis done by 3 months of age and then intervention starting at 6 months of age. So those are our kind of current national goals for EDI at the national level, the state level, all that things. This I found a really interesting study. This is by the same author who did that other study that I talked about, and that this was looking at the actual outcomes for goals. And this kind of, and again, this is just a snippet of what they showed here, but they found that what the data is showing is the quotient of language appropriate for the child's age compared to normal hearing peers. And they actually found a statistically significant improvement for the children that meet all 3 goals, which includes if you have a child. So that means that we got better results for children who had their screening by 1 month, in diagnosis by 3 months, and intervention started at 6 months, versus the group of children who maybe their diagnosis was late, maybe they were diagnosed at 4 or 5 months, but the team still got the intervention started by 6 months. And those children did slightly less, which doesn't really make any sense, but I think it just goes to kind of give some reinforcement that the 3 matters in the 136 goals, that there is some benefit. I don't know if I really can't explain why, other than maybe the people that are meeting the diagnosis goal have parents that are more on top of things and follow through better. I have no idea, but it's kind of a really interesting status. I didn't put it in the study, but I also recently looked at a study that looked at the children who got their diagnosis by 2 months and intervention by 3 months, and they didn't do much better than the children meeting the 136 goals. So their conclusion is maybe 136 is pretty good, and we really ought to double down on trying to meet those goals, for these children. So, how good are we at doing that? So in the state of Michigan, we're pretty good at looking in the lower right-hand corner here. We're pretty good at getting the hearing screening done by 1 month. 95% of that. Getting the diagnosis by 3 months, pretty good at it. We miss that about roughly 20% of the time, and then we're even worse at getting intervention started by 6 months. One of the biggest issues where the EDI programs probably need help or need collaboration or still have work to do is the loss to follow-up. The kids that refer on their hospital screening but never make it back in. So statewide, we have a lost follow-up rate close to 47% year over year, which is these numbers here. Here on the bottom is Michigan Medicine's number. We're slightly better than the state average, but we're still at roughly 40% loss to follow-up. And so, I mean, this is clearly a place that, primary care physicians and other nurses can have a, a role in kind of encouraging or supporting these families to get back in for their hearing screening. So just a couple comments on how we actually do the hearing screening. You're gonna usually, there's two tests you can do. One is called an automated auditory brainstem response. Basically gonna play like clicks in the baby's ear, and then the baby's gonna have to be asleep for the test. Was someone talking, asking a question? No, okay.
Yeah, Greg, I have a quick question regarding the prior slide. I know we're so ways off from meeting the 136 goals. So I wanted to just kind of probe a bit more on the communication strategies, because I know often when we get these screening updates, whether they pass or not, it's often buried in often like a newborn discharge. There's not really a very clear communication with family medicine providers, and I don't know if the same thing also for pediatricians. Could you tell us a bit more about that process? I know it seems like the communication is often facilitated in the hospital, but not much engagement unless we're really looking through. I had a recent newborn who actually failed, and just being mindful of this topic, was able to see it that it's already been set up for a repeat screening. Could you just walk us through what are the strategies and steps to engage primary care providers into that to hopefully kind of help move the needle a bit more?
Yeah, well, I'll be honest, it's been 20 years since I've done actually any of the screenings myself. Back then, I think we were sending a letter to the primary care. I will have to ask Katie that and get back to you. I do know that what happens is that at Michigan Medicine, our techs kind of, as soon as they determine someone has to go in, they just immediately put it on the schedule, and then the parents are given a handout, with some information about the screening, kind of what it means. And then I know that the audiology department does a follow-up call on every patient who's scheduled for the screening, and also gives them kind of instructions for the test, mostly to make sure the parents know we're going to have to get the child to sleep for the follow-up diagnostics. But I actually don't know the mechanism for informing the primary care provider. I'll have to find out for you that.
Thank you.
Yeah, let me jot that down. And then I will ask her today and then just send an email back to the group. Any other questions? So the other thing I wanted to point out, so that these met and unmet goals here is the children. These are our goals for the people that actually come for follow-up. I don't believe this includes the loss to follow-up rates, right? So that's why this is not, higher unmet goal.
Greg, there's one question.
Yeah.
But we have a hand up from Samantha. Samantha?
Yes, Samantha.
As a parent who experienced this process, and I'm also a member of the EDI advisory board for the state, the language used at the time of the newborn screening in the hospital did not provide any sense of urgency to me as a mom that I needed to bring her in right away for a follow-up. The technician or the nurse just said, oh, it's probably nothing. There's probably just fluid in her ears. So I'm the type of parent who would, of course, follow up and make sure that's completed, but I'm pretty confident that not all parents would respond in the same way.
Yeah, I do know that they struggle with, creating a unnecessary anxiety in parents, versus kind of designated the importance of it. I do have some slides on here on kind of like recommended language, and you know, and saying it's probably fluid is probably something we should not be saying, even though the reality is probably the vast majority of the time that's what it is. But you know, I think right, it creates a false sense of security that there's nothing, you know, nothing wrong here, you know. And I can tell you firsthand that most of the time, the vast majority of these kids, when I see them for follow-up, they pass just fine. But every so often, you know, you'll see someone who's got, you know, real deal hearing loss, you know, and that's a hard thing because often it's not transparent. And this is the first time, you know, like 5 minutes ago, you had a perfectly normal baby, and now someone's saying, you know, oh, now your baby has a problem, because it can be invisible. So yeah, so we do automated ABR, and we're just playing clicks in the ear, and the machine is looking to see, do we see the right brain waves that you would expect to that, which then gives you some indication that the hearing mechanism is working. I think it's important to note that, you know, that when we test these ABR tests, right, like we would consider 20 decibels normal hearing. They're testing hearing at like usually 30 to 35. The EDI screening is not designed to catch every single mild hearing loss, you know, and it's all about moving the numbers to get the sensitivity and specificity of your screening you want. But I think it's important for primary care people to know that the newborn hearing screening might not catch a very mild hearing loss. So if you've got a parent with concerns or reporting or whatever, then it would still be worth you know, don't say, oh, your screening was good. You know, we always say that the #1 risk factor is a parent concern. The other test that that you can do, which is kind of not done very much anymore, is something called otoacoustic emissions, or OAEs. When your outer house hair cells in your cochlea kind of work, they create little tiny echoes. And if you put the right kind of microphone in the ear, you can actually hear them working, which gives you a pretty good indication that that the ear is working fine. OAEs will miss. There are a couple types of pure nerve hearing loss that have nothing to do with the cochlea. This test will completely miss that on a newborn hearing screening, and that's kind of why OAE screenings have kind of gone out of fashion. You can also pass this test with a very mild hearing loss. So, you know, just things to be aware of. And so generally the outcomes are either going to be, for each ear, it's either going to be, they're going to pass in both ears. The patient will be discharged for monitoring. They're going to be provided on a pamphlet on normal speech, language, and hearing development, and counseled that hearing can change, albeit rare, but they shouldn't ignore concerns, you know, that develop down the road because we had a good newborn hearing screening. You can pass, but then in your history have some risk factors that will put you at risk for developing hearing loss. And so if the EDI screeners notice something in someone's history, they'll recommend kind of some routine monitoring. You know, kind of there's a number of different risk factors. Kind of the big ones that we're typically concerned about is family history of congenital hearing loss, a syndrome associated with hearing loss, bacterial meningitis are the ones that we watch really closely, because they, even if they're normal at birth, they're at higher risk of developing a problem down the road. Or you can have a referral. That means one or both of your ears did not pass the screening. In the newborn, they'll repeat it one more time, but won't do it again. And then if it's not better at the rescreen, then they'll schedule with audiology. So here's that slide I was talking about, where this is kind of the recommended, this is developed by the Michigan, so this is a state level EDI program, kind of their recommended language for what this means. And I think as a primary care provider, pediatrician, family medicine, you know, this might be good language to use if you're asked about it too. So, you know, you kind of try to give a positive message saying you didn't pass the hearing screening. it's really important that we take another look. It doesn't mean that you have a hearing loss, right? And then you want to give the parents some information, and then reinforce that you want to get it rescreened by 1 month of age. So so if they don't pass, they can come back in. Like an option would be to, like, there are certain centers that will do just an outpatient rescreen, so they don't do a full diagnostic eval. They'll test them once, like try to get them back within a month and do this hearing screening again, rather than doing a full screen, because not every site has the resources to kind of jump right into diagnostic. Now, at Michigan Medicine, we just schedule them immediately for a diagnostic. We're one of the tertiary follow-up centers, so we kind of just skip the outpatient rescreen and go right into diagnostics because we have the resources to do that. So anyways, so was there a question? Anyway, so the following up testing intervention that would happen is the infants who refer on the screenings are kind of scheduled for a follow-up, the threshold ABR or that other test, ASSR. If the hearing loss is diagnosed, they'll undergo an otologic and audiologic workup. So we'll test kind of a much broader range of hearing that's tested on the screening. We will usually make a referral to early education referral. So we'll make a referral to early on, and they'll usually send out a speech language pathologist to the house to do some initial counseling, and referral to other support groups that exist. There's like a guide by your side program that gets parents in touch with other parents who have hearing loss, things like that. Audiology, then, once we kind of confirm the hearing loss, we usually never go off of one hearing test alone. We usually we usually can't get the whole test done in one session anyway. So we usually do two, so it'll be roughly about 4 hours of testing. A lot of that is just waiting for babies to fall asleep because they still have to be asleep for these tests. And then we'll do an evaluation for hearing aids or cochlear implant, or sign language resources if parents want to do that, and then set up monitoring for those. Anyone diagnosed with hearing loss is going to need routine follow-up, or anybody who still passes the testing but has a risk factor will continue to set up monitoring. Anyone that is found a hearing loss will make a referral to pediatric otolaryngology, where they'll talk about further testing, CMV testing, imaging, which they usually don't do until a couple of years later, EKG, ophthalmology, and genetics. And then I already mentioned speech and early on. So this, in each section, I put what I would call the hot topic in things. So the hot topic in kind of pediatric audiology is cytomegalovirus, or CMV, which is kind of one of the leading causes of non-syndromic hearing loss. So among all children with bilateral moderate to profound hearing loss, about 15 to 20% of these cases are can be attributed to a congenital CMV infection. There is currently a bill that was presented in the Michigan House, which is just basically to add CMV to the list of diseases that they're screened for at birth, just on all children. Minnesota last year was the first state to implement a bill like this. I think there's also mutterings of a federal bill. And certainly this is a thing where, getting physicians involved, could be quite helpful. And I don't know what other physician groups are kind of in support of this bill, but, I would just point out that for about 20 years, audiology has been asking for like routine CMV testing on all children with hearing loss, and we never really got anywhere with it. And at Michigan Medicine, it really took one highly motivated developmental pediatrician, Dr. Pesh, who like basically hammered this through, and is now actually, I think she still is personally ordering a CMV screening on everyone we diagnose. Like, so I still think it's all really on her. But that's kind of the hottest topic in the EDI world right now is really looking to CMV, So just in summary, I think, primary care, public health cabulation, I think understanding the importance of the 136 guidelines and the implications of delayed intervention on long-term language development certainly has a role in supporting families, encouraging them to follow up, and knowing things that like, a referral doesn't mean hearing loss, but it's still important that you follow up and kind of the critical messaging. There's a clear need to improve our follow-up rates. I think it's important to understand that newborn hearing screens are not designed to catch every minimal hearing loss. And then just public health and advocacy, garnering support for passage of like the CMV testing bill. So that is the end of the EDI part. So I'll stop and just ask any questions, comments, brilliant ideas. Okay, I will move on to an area I worked, more directly with. So screening in kind of adults and geriatric populations. So same idea. Why should we screen in older adults? Well, hearing loss is prevalent. It's in 1 in 3 Americans between ages of 65 and 74. Once you hit 75, it's about 50% of Americans. Presbycusis occurs so gradually that most adults don't realize it's happening. And so screening programs can result in early detection and intervention. Same thing. So diagnostic audiology is widely available. It's more widely available for adults in more rural places than it is, for the infant sides. We don't need like the centers of excellence like we need for the EDI program. And there's a readily available interventions for almost all types of hearing loss. Sometimes it can be medications for conductive hearing loss, surgery, hearing aids, cochlear implants, or implantable hearing aids, bone conduction hearing aids, all kinds of options. And then I'll go through this, some of the other benefits of treating hearing loss. There's some research that's showing, regardless of balance status, vestibular status, hearing loss and kind of increases your fall risk. There's a clear link between social isolation and depression in older adults with untreated presbycusis or age-related hearing loss. Maybe cognitive decline. We'll talk about that's our hot topic, and this is a study that just came out that was looking at cognitive decline and hearing aids potentially slowing that. Improvement in social emotional impacts in the hearing loss, and then the obvious one is ease of communication. So presbycusis, this is determined as a bilateral age-related hearing loss, and it's likely a combination of several internal and external factors. So, our cochlea is a highly metabolically active part of your ear. It's always working, asleep, awake, and it doesn't have a robust blood supply. It doesn't have a lot of backup. And so any kind of little infarct or whatever can cause permanent damage. We also live in a really noisy world, so a lifetime of noise exposure is probably causing us some damage, and there are other comorbidities, links with diabetes and things like that. So literally it means old hearing, and it's the most common cause of hearing loss in worldwide. Also, age-related hearing loss is the 3rd most common chronic conditions in older adults between high blood pressure and diabetes. So, according to Dr. Kelly, my primary care physician, I've got the first 2 of those, so I'm just waiting on the hearing loss to get the trifecta. I love this data here. So this came out a couple years ago in Japan, and it's showing kind of in these different men and women groups, ages, and they looked at hearing acuity, decade by decade, sometimes even 5-year increments. And what this really, if you look at this, shows is that, we call it aging related hearing loss, but really, it's really a lifetime of change in your ears. And so it's almost like you're born and then your ear almost immediately starts not working as well. But it just turns out that when you get into your 60s on average, the effect of the hearing loss is more likely to affect the speech frequencies, the frequencies of hearing. They're going to have an impact on day-to-day communication, and that's when people start noticing problems. But it's really kind of this gradual, almost lifetime decay. And like looking at this data really almost reframed how I think about presbycusis. This is a really interesting study. This just is a couple-year-old study. I put references, if you go into the slides, by the way, in the speaker notes, going to be all the citations for this data if you're interested in that at all. But this was just showing kind of these undesirable outcomes. This is just in patients with untreated hearing loss who are admitted to an inpatient hospital setting. And this study showed that these patients had longer length of stay, higher costs. They were at higher risk of complications or longer stays. They didn't always have access to all the things that they should within the American with Disability Acts. And then they also had lower post-discharge adherence and higher readmission rates. Another kind of indication of how hearing loss can affect things other than just your ability to hear your spouse or hear at a restaurant. This is an older study, I think circa 2007, but the NIDCD VA did this long-term study to try to demonstrate the benefit of hearing aids. And again, there's lots of data in this, but I just highlighted this, which kind of showed hearing aid benefits helping people in some of the what they call psychosocial impacts in social environments, work environments, home environments, showing that these patients had more benefit in those environments than people untreated with hearing loss. I had to put this one here because this is the Michigan Medicine study. But this was looking at risk-adjusted hazard ratios of being diagnosed with hearing loss, being diagnosed with dementia, anxiety, and depression, and falls within 3 years after their hearing loss diagnosis. In the data, I think Dr. Zazo was on this study. I don't know if anyone else here was, but showed some mitigation of all of these lower risk indicators for all of those and those who used hearing aids versus those do not. And then this is the one that I get asked about almost every day by patients. This study has gotten into the zeitgeist of the population, which is called the Achieve RCT study. So it's going to be our hot topic in adult hearing screenings. But this was kind of the first randomized control trial that looked at hearing aids and their ability to affect cognitive delay. And basically what they did is they looked at patients with hearing loss in another study, which was you guys may be familiar with this. But it's a atherosclerosis risk group, and basically a group that they deemed was at higher risk of cognitive delay than your average population, versus a newly recruited, healthier group of patients. And they showed that over time, that the higher risk group, their cognitive delay was slowed by hearing aid use versus not seeing much of an effect in kind of the healthier population. This one is really interesting to look through if you're interested in this, looking through their website. They've got a ton of data and stuff, but but I think the authors were very careful to point it out that they saw some effect in higher risk patients, and that they pointed out that slowing cognitive delay doesn't equal to preventing dementia. But I get patients showing up in my office saying, I want to get some hearing aids, I don't want to develop dementia, right? So clearly this has gotten out there, and this is the one study everybody's kind of talking about. So but that's just kind of a summary of some of the benefits of intervening hearing loss, besides just making communication easier in adult populations. So when you're going to do a hearing screening in adult, you're going to think about it slightly different than you're going to in a, I just want to check how I'm doing on time. I'm a little behind, so I'll speed this up. But generally, you're going to do some sort of health history questionnaire. And the idea is you're going to be looking for red flags for patients who might need an ENT referral or laryngology referral, in addition to just being sent to audiology. So looking for asymmetric problems, unilateral problems, vertigo, things like that. You're generally going to want to do otoscopy because cerumen impaction is could be it's an easily fixable problem that we might want to clear up before getting to audiology, and any other pathology that would kind of result in a referral to otolaryngology. So that you would have your visual otoscopic inspection. Then you're going to do a pure tone screen. So we're going to, usually this is done with a portable audiometer, and you're going to basically test at like 25 decibels at a couple of important pitches for hearing screening and see if the patient reports hearing it or not. Usually you do this at about 1,000, 2,000, 4,000 hertz. Those are the frequencies that kind of really, really matter for understanding in conversations. And either the patient responds or not, and then kind of record it on a form whether or not they responded. Some hearing screening programs will test just different frequencies, but for time and efficiency, those are kind of the core ones that you would want to do. And then the other thing you want to do in adult is gauge their perception a little bit of how they feel a hearing loss is impacting their day-to-day lives. Because it's, in children, it's urgent that you get intervention because it'll have lifelong impacts. Adults, they have some say in the matter. So, so you want to gauge some access on the impact of hearing in life. So my favorite is the hearing handicap inventory screening called the HHI. It's just 10 questions scored 0 to 40. It's a questionnaire that's built into Epic, so anybody can assign it to a patient. We have it as something the patients fill out before they come in for an audiogram, but any MyChart user can give this to a patient. And it's really easy. It's just basically 10 questions. There's slightly different questions you ask, a couple of different questions you ask based on their age. And the patient just asks if it's a problem, yes, no, or sometimes. And it gives you some gauge of how the patient feels. And I will say that this really doesn't necessarily correlate well with degree of hearing loss. I have some patients with minimal hearing loss who feel like their hearing loss is devastating their lives and will score off the charts on this. And then some people, I'll look at their hearing tests and I'm like, how are you functioning day to day, without help? And they come in with a score of like 6, 4, like, they don't perceive that they're having a problem. So it's really gauging something else than just hearing. It's their perception of handicap. So one of the other things you guys asked me to touch briefly on, I don't want to run you over, was kind of over-the-counter hearing aids versus professionally fit hearing aids. So very briefly, over-the-counter hearing aids starting last year in January became approved by the FDA. And they're approved for patients with mild to moderate hearing loss. And there's a wide variety of hearing out. Some are just preset, others are adjustable to the patient. They're going to range from $300 up to $1,800 for a pair of them, depending on which ones you get. the most expensive one on the market are come from Jabra, but they also actually offer some actual online support for their devices. But those are the kind of the $1,800 ones. And then you have professionally fitted hearing aids. At U of M, they're going to range somewhere between $2,000 and $6,000 for a pair in services. So, you know, the cheapest hearing aid at U of M is going to be more expensive than the most expensive over-the-counter hearing aids you can get. Sometimes you can have insurance coverage, which won't help with over-the-counters. Medicaid provides full coverage for hearing aids. And then the patient will also get a consultation of the various options to support individual communication needs. And then if they're professionally fitted, the patient's going to get some additional testing, verification, and validation, kind of demonstrating that you know, because a lot of hearing aids will set for what the kind of the average person's ear canal size is, but the size and shape of your ear can have somewhat dramatic effect on how the hearing aid operates. So you can really fine tune it by doing some additional testing. I just wanted to point out that, you know, barriers and opportunities. So one of the barriers is that right now it's like a 6-month wait to get into a hearing aid evaluation with our adult providers. So we have really limited capacity to see more patients. Our boss is very enthusiastic and he always wants to like advertise our hearing aid program and get more patients in. And we tend to freak out because we can't handle the volume we have already. An opportunity that we have is we just now this week got a mobile audiology clinic that we're going to use to kind of go out into the community and start some screening programs. Our pediatric team is going to, they're working with the Amish community, taking some of the services up there. They're hoping to collaborate with the Ypsilanti Health Center because the Ypsilanti is kind of a hot spot for loss to follow-up rates. So they're going to try to provide some services more locally. And then we're going to expand our collaboration with Hope Clinic with the mobile clinic. So I think I've helped on this already, but you know, in adult populations, I think we can almost start promoting the idea that good hearing health can contribute to your good general health. Here and I'll quote a summary of an article that was Dr. McKee was the primary author on, and it was that hearing loss globally affects health and healthcare. It is not only common but remains largely overlooked, resulting in significant inequities and adverse outcomes for patients with hearing loss. McKee et al. 2023. I think we have opportunities to collaborate on public outreach, community hearing screenings, health screenings, you know, and then maybe down the road, this is just a pie in the idea, but, you know, could we develop some more comprehensive like hearing healthcare program where these patients can get primary care, psych, otolaryngology, fall risk, you know, PT, you know, for some of our patients that are high at risk for some of these issues associated with hearing loss. And that's all I have for you guys today. And I think sorry I didn't leave as much time as I thought for questions, but I'd be happy to take any ideas, suggestions, thoughts, or whatever.
Thank you so much, Greg. This was really helpful and a lot of great material, you know, already covered, and we'll make sure we'll get this out to our department as well. So I want to open it up for some questions. I certainly have a couple follow-up questions, but I want to see if others have an opportunity to chime in, maybe share some experience or questions on their end. So I do agree with you about the need for better coordination of care, and I know Dr. Pesh, myself, and a couple other people did meet with ENT about this concept of how we could coordinate care with family medicine and otolaryngology, audiology, just to get more wraparound clinics, whether just having better tools to assess, because some of these tools are not appropriate for deaf or hard of hearing individuals, and just being mindful about some of the issues that do come up. So I totally support that. And we actually were going to be reaching out to you and other folks in audiology on how we can hopefully take the next step forward. And then the second thing is, was curious if you've had some interactions or results from the best practice alert from the EAR-PC project. I think right now you're probably still getting some referrals, maybe not as much as what we had in the prior project period, but it is still live in our department. So it's a single item. Do you think you have a hearing loss? And if they do, it prompts a referral through a smart set. I don't know if you've had any of those come through.
I don't know that I generally don't know the referral source of the patients coming to me for a hearing aid evaluation.
Okay.
Probably because in my responsibilities, I'm not doing the diagnostic audiograms. So generally, when they're referred to audiology, they're referred for an audiogram. And then it's the audiologist or the otolaryngologist who's sending them on to me for the hearing aid. So yeah, I don't generally personally see, but I can ask some of my colleagues who are doing that. I'll put that on my list of things to ask about. Best practice alerts.
Oh, so we have Linda Long. Hello.
Hi, can you hear me? Yes. Can you tell me a little bit about your experience with school age screening?
I personally have very, very little experience with school age screening. The school age screening in Michigan is handled entirely through the public school system, and they have a pretty extensive protocol. So what I do know is that at certain age groups, like I don't know if it's first grade, fifth grade, there's a couple age groups where they try to screen the kids, and they do an initial screening, which is like 4 frequencies. If they don't pass that, they will come back and do a much more extensive one, testing more frequencies, and then if not, they will basically do, it's like an unofficial actual audiogram. So they'll actually try to not move beyond the screening to kind of get some idea of what the screening is at. So it's not like a great, because it's not done in a sound booth, and but it at least gives you some idea what you're thinking. And then that will trigger a referral to audiology, and it should trigger a referral to the primary care physician.
At what point in there do they notify the parents?
I do not know the answer. I assume the parents are getting notified after each screen, because they're going to have to tell them what kind of the status is.
Right. I asked because it hasn't always happened that way in Massachusetts. So
yeah.
Thank you.
Yeah. Well, thank you so much, Greg. I really appreciate you coming over and talking to our group. Lots of excellent information, and I know all of us need to do a better job to address these gaps. And I'm confident we are going to continue to improve, given that there's a growing awareness on the gaps and how they impact the patient and also our healthcare system. So thank you, everyone, for joining, and we look forward to seeing you next month.
Yeah, I really appreciate the invite. I didn't even know this group existed, so thank you very much for thinking of me, and I appreciate your ability to present this to you.
Thank you.
Thank you.
Bye-bye, everybody.